Welcome to this podcast series on healthcare quality, where we take in this sixth episode a closer look at the hidden impact of adverse events in healthcare, the stories we often don't hear about, but must confront. I'm Chris, and as a university professor and researcher in healthcare management, I've spent over the past 10 years exploring these complex dynamics that deeply affect professionals, patients, and entire organizations. From the beginning of our journey on second victim research, I had the privilege to collaborate with my now postdoctoral colleague and friend, Dr. Deborah Sees. Together with Deborah, we conducted several studies on this topic, and we are also part of an international research team, the European Research Network on Second Victim Consortium, under the lead of our Spanish colleague, Professor Jose Mira, and German colleague Reinhard Strametz. The podcast today is based on an online lecture I gave in the class of my mentor and friend, Peter Lachman. Peter leads a class on healthcare leadership in Ireland for the Royal College of Physicians, but he also leads a class for our colleagues in Africa with friends from Nigeria, Kenya, and Tanzania. I had the honor to share my experience with second victim support systems, and this podcast is based on that lecture. So thanks for the opportunity to Peter and the international students. Let us start with the content for this episode, Second Victims After Adverse Events. Today, we are beginning a journey, one through which we will explore what lies beneath the surface of clinical practice. When things go wrong, when systems fail, or errors unfold, the implications ripple far beyond what meets the eye. Yes, these moments shape the experiences of patients, but they also cast longer shadows on those delivering care. We've named this podcast The Hidden Impact of Adverse Events, because in all honesty, healthcare occurrences aren't just clinical. They're deeply human. They touch emotions, disrupt motivations, and often lead professionals to question their knowledge, abilities, or even their sense of purpose. In this episode, I want to take you beyond data points or incident statistics. We'll dig into how healthcare workers, the so-called second victims, respond and recover from unintended outcomes. What toll does the work environment take on their mental well-being after such incidents? And what can organizations do to ensure strength and security for their workforce? The foundation of this discussion lies in acknowledging that resilience doesn't develop in isolation. No healthcare professional, not even the most experienced surgeon, physician, nurse, or manager, can always stand unaffected. The negative reactions after being directly or indirectly involved in an incident, well, I think they are normal. And that is because these reactions are just human, nothing more, nothing less. But we need to make sure that these reactions do not last, because then we will lose our colleague. Their recovery and ongoing contribution to patient safety rely heavily on the system, the leadership, and crucially, the level of compassionate support they receive. Throughout this series of podcasts, we already highlighted models of patient-centered care that expand to human-centered care, a philosophy that understands the healthcare workforce as intrinsic to the safety equation. You heard in previous episodes about groundbreaking frameworks like the multidimensional model, Our House of Trust, about the history of quality, about psychological safety. And now I'll introduce the evolving insights into the phenomenon termed second victims. Whether you're a clinician, a student stepping into this field, or a manager shaping healthcare culture, this podcast is for you. Together, we aim to foster understanding, compassion, and actionable strategies. So, as we prepare to dive into definitions, stories, and efforts with this first conversation, I invite you to reflect, a moment of pause, to consider just how deeply the act of care connects every one of us. But sometimes care does not go as planned. In the world of healthcare, where excellence and precision are paramount, even the smallest deviation can have profound consequences. But what happens to the caregiver when that deviation occurs? How are they impacted? It's here that the concept of second victims emerges, a term first introduced by Dr. Albert Wu in the year 2000. That is 25 years ago. The definition has evolved over time, culminating in a consensus-based update in 2022. This consensus definition was developed with our international ERNST team, and I have the honor of being first author of this landmark publication. The European Research Network, working on second victims, concludes that a second victim is nowadays defined as any healthcare worker directly or indirectly involved in an unanticipated adverse patient event, an unintentional healthcare error or patient injury, and who becomes victimized in the sense that they are also negatively impacted. So let us repeat that definition, as it is crucial in understanding the phenomenon. Any healthcare worker directly or indirectly involved in an unanticipated adverse patient event, an unintentional healthcare error or patient injury, and who becomes victimized in the sense that they are also negatively impacted. Let us dig in deeper in 3 different parts of this definition and start with any healthcare worker directly or indirectly involved. This means that all multidisciplinary and interprofessional team members can become second victims. Not only doctors and nurses, but also allied health professionals, cleaning personnel, volunteers, administrative support, and the management. These healthcare workforce members were directly or indirectly involved. So also members of the team who were not directly involved in the event can suffer in the aftermath of such an event. Secondly, we talk about unanticipated adverse events, unintentional healthcare error or injury, patient injury that was unexpected. All of these types of events can lead to an impact on the healthcare professional. So we are not only talking about proven medical errors, but a broad range of incident types or even patient injury because of unforeseen and unintentional complications. Thirdly, we focus on healthcare workers who become victimized in the sense that they are also negatively impacted. As discussed in other ERNST working groups and in our work on support systems, healthcare workers are negatively impacted on psychosocial and professional level. But important in this part of the definition is the word also. The word also. With also, we mean that the healthcare professionals are not the only and certainly not the most important victim of such unanticipated events. We hereby express that the most important victim of such an event is the first victim, and the first victim is the patient and or the loved ones of the patient. So let us conclude with some main messages about the 2022 definition. First, we developed an evidence-based and consensus-based definition, including the recent literature and many international experts. Everybody supporting patients can become second victim. And thirdly, and most important, first victims remain the most important victims of incidents. But healthcare workers need to be respected, and many of us need support in the aftermath of such an event. So that is about the definition, but what about the numbers? What do we learn from research on number of second victims? Statistics reveal the scale of this phenomenon. Over 50% of healthcare workers are likely to become second victims during their careers. And while some incidents involve no harm to the patient, Others, like medication errors or procedural mistakes, can lead to temporary harm, permanent disability, or tragically, even death. But if you remember in one of our previous podcasts, the one on human error, for example, we discussed the number of adverse events. The World Health Organization estimates that more than 10% of patients in hospitals in high-income countries are involved in suboptimal care or adverse events. So when I read in the literature that the number of second victims is, as we say, around 50% of the workforce will become second victim during their career, I think that this is a total underestimation. 50% is a total underestimation. I think that nearly every healthcare worker will become second victim during their career. Not all with a very high traumatization, of course, but they will experience negative reactions on personal, social, or professional level in the aftermath of a serious and also less serious clinical adverse event. When we acknowledge the reality of these experiences, it becomes clear that the ripple effects of adverse events extend far beyond the initial incident. They challenge not only professional integrity, but also personal identity, leaving individuals questioning their place in the very profession they once felt called to. When discussing adverse events in healthcare, we often focus on improving systems, protocols, or patient outcomes. But there's another, less visible impact, a deeply personal one, on the individuals delivering care. For healthcare workers, the experience of being involved in an error or adverse incident often brings with it a range of emotional and psychological symptoms. Hypervigilance is one of the most reported reactions, where clinicians become overly cautious, checking and rechecking every detail obsessively. This symptom alone can stretch far beyond the workplace, affecting someone's everyday life. The impact of hypervigilance is fatigue. In our paper on durations of the reactions published in the BMJ Open, we wrote that over 50% of the clinicians in the study reported hypervigilance for over 1 month and 24% for over 6 months. Stress is another pervasive reaction, often compounded by guilt, an overwhelming sense that one has failed their patients or colleagues. A crucial part of this experience involves doubts about knowledge and skills. Doubting knowledge and skills was reported by 27% of the clinicians during more than 1 month, and 8% reported this for over 6 months. And we know that if clinicians are doubting their knowledge and skills, they have higher risk of becoming involved in new patient safety incidents. Doubting is not good. Thinking twice is, asking support or checking something with a colleague, that is professional attitude, but keep on doubting yourself is not good to deliver high quality care. The study I'm talking about is a study we performed in the Netherlands, including nearly 5,000 clinicians. So hypervigilance, shame, stress, doubting knowledge and skills were reported, and even flashbacks were often reported and lasted more than 1 month in 23%, and even in 9% during 6 months, which brings these colleagues in the high-risk group for post-traumatic stress disorder. Even seasoned professionals report feeling unprepared or unsure of their abilities after such incidents, leading to erosion in self-confidence that can linger for months or even years. The duration of these effects can vary, but studies, particularly those from Belgian and Dutch hospitals, show a troubling pattern. Read our papers in the BMJ Open. Some of them are already a bit old. They come from a very interesting PhD study by Eva van Gerven, who now works for the largest fire department in our country. But she made the first PhD on second victims years ago. And some of our papers are more recent, but what I find interesting is that the numbers do not change. And the list of symptoms or reactions of second victims. These reactions also do not change over time. That is because they are just human reactions. Our different papers and our team has more than 35 papers on this topic. These papers all provide an overview of the most important numbers, reactions, and the lasting impact. In one cross-national study, Eva van Gerven found a twofold risk of burnout in the 6 months following a serious adverse event, but also higher turnover in tension, work-home interference, and higher medication use. These type of reactions do not exist in isolation. They influence how individuals communicate, collaborate, and perform within their teams. This tension undermined teamwork, delayed critical decision-making during subsequent cases, and ultimately compromised patient care. It's a potent reminder that the professional impact of adverse events can ripple outward, affecting the very systems designed to keep patients safe. And I think that there is an important link here with psychological safety. If you did not yet listen to the podcast on psychological safety, please do. So please, please, please let us not underestimate the number of second victims, but also let us not underestimate the reaction and the duration of the reactions. So how do we address these hidden but far-reaching reactions and hidden costs to our healthcare workforce? Yes, there are also additional costs. In a study in Italy, together with my friend Massimiliano Panella, we found, for example, the significant higher numbers on defensive medicine after being involved in these events. So, the management question is, how can leaders ensure that affected individuals feel supported rather than isolated or judged? Understanding that these professionals are not immune to human error is one step, but creating environments where psychological safety is prioritized in the aftermath of adverse events may be even more critical. These are questions we need to grapple with earnestly as teams, institutions, and as systems of care. And these human costs, while less visible, must hold the same level of importance as any other metric of safety in healthcare. So we discuss the definition, we discuss the numbers, and we discuss the impact. As we delve deeper into addressing the aftermath of adverse events, let us consider a structured approach to supporting those affected. My colleague Deborah performed a literature study on this and published the results in her paper in the BMC Health Services Research in 2023. She came up with a 5-level pyramid. This 5-level support pyramid is a framework that provides a clear roadmap for intervention. Please take a look at this model because I am convinced that this model can help you as an individual, but also it can help your organization in building an evidence-based peer support system. This 5-level model starts with prevention at its base. Prevention works at both individual and organizational levels, equipping healthcare professionals with resilience-building strategies and fostering a culture where errors are treated as learning opportunities rather than personal failures. The second level focuses on self-care, both for individuals and teams, encouraging reflection and creating safe spaces for clinicians to process their emotions are key here. Many find relief in informal conversations with trusted colleagues where they can articulate their experiences without fear of judgment. Self-care extends to recognizing emotional distress and taking proactive steps such as mindfulness or seeking wellness resources. Peer support is the third level of the support pyramid, an important level. This peer support often bridges the gap between isolation and formalized help. Trained colleagues who understand the nuances of healthcare work provide timely, empathetic listening. Importantly, these peers are uniquely positioned to destigmatize seeking help, as they often share similar experiences. Such initiatives have proven invaluable in cultivating a sense of solidarity and validation among staff. But these peers, although they provide care, they do not provide real structured support. They're even more a triage system. They need to find out if the colleague is okay or that he or she needs more structural support. So we have 1, prevention, 2, self-care, and 3, peer support. Next, on the 4th level of the pyramid, we have structured professional support. This 4th level introduces external expertise, be it psychologists, counselors, or mediation specialists who can navigate the deeper systemic facets of a clinician's stress or conflict. This is where the individual receives the tools to process their experiences constructively, addressing unresolved trauma or rebuilding confidence. The 5th and final level involves clinical therapy, the most intensive form of support. This includes interventions such as evidence-based psychotherapy or medication when reactions to adverse events lead to prolonged, severe psychological distress. It's an acknowledgement that even the most resilient individuals sometimes require professional intervention to heal. And that is not something that they should be ashamed of. Not at all. These 5 levels are not rigidly sequential, but flexible, allowing healthcare organizations to tailor their support based on the individual circumstances and immediate needs of their workforce. Yet, beyond supporting individuals, a culture of transparency within organizations is vital. When leaders prioritize open communication, when they actively listen and respond without assigning blame, they foster psychological safety, a state that is crucial for recovery and ongoing team effectiveness. Leaders must also embody compassion and accountability. By setting an example, acknowledging errors without punitive measures, they lay the foundation for organizations that value honesty, growth, and human dignity. It's this alignment of support and culture that ultimately transforms not just how we respond to adverse events, but how we prevent them from recurring in the future. So let us be clear. My personal opinion is, of course, that we need to take second victims very serious. No discussion about that. But next to taking care of our colleagues, we need to be open to discuss why things went wrong. Some of the adverse events are really medical mistakes. And sometimes they are, and I hate the word blunders. Sometimes it is really about human error. Sometimes it is really about stupid mistakes or risky business, taking risks, not following protocols, violations. So this means that we always have to discuss the learning points. And that is why I think, and we have the experience also at our Leuven University Hospital, to include the second victim support work in our root cause analysis and discuss it as part of our morbidity and mortality rounds. I do not believe that second victim support is some standalone project. It should be integrated into the overall quality and safety work, but we need to make sure that the governance structure makes sure that we can openly discuss everything, and we may not forget the basis principle of this work. To err is human. As we reach the conclusion of this conversation, it's worth reflecting on the foundations we've explored and the direction they point us toward. Throughout this series, we are discussing the interesting field of quality in healthcare. In this episode, we've grappled with the profound impacts of adverse events, not only on patients who are our foremost priority, but equally on the healthcare professionals, the second victims who carry the emotional and professional weight of these incidents. To truly reshape the way we respond to these moments of crisis, we must embed these learnings into practice at both the individual and institutional levels. This is where the multidimensional quality model comes to life, a framework that navigates far beyond metrics or compliance. It urges us to consider care from every angle. Patients, their kin, and indeed professionals as integral to ensuring healthcare quality. The House of Trust further reinforces this by emphasizing trust as the cornerstone of healthcare. Trust both from patients and among those delivering care. Organizational leadership must remain steadfast in supporting this model, subscribing to values of dignity, compassion, and partnership. Why? Because a culture built on such principles is not only safer, but also fosters resilience when things do go wrong. Let us not forget that healing is a journey, not just for those we treat, but for those delivering the treatment too. An error or unforeseen event is a moment of crisis, yet also one of learning. It's an opportunity to reinforce systems while ensuring no individual is left to suffer in isolation. Through consistent, empathetic support structures, the kind outlined in the 5-level pyramid, we affirm that every professional has a rightful place within this house of trust. And as important as these systems are, it begins with how we, as individuals, choose to lead through our actions. Every compassionate conversation, every instance of reframed accountability creates ripples that shape the culture of tomorrow's healthcare. Let us uphold the principle that quality care is as much about fostering trust within teams and organizations as it is about patient outcomes. So, as we close this 6th episode of my podcast series on quality, I leave you with this thought. Resilience develops through connection, through the support we extend to one another, and the structures we build to ensure that care remains human-centered, holistic, and profoundly compassionate. Always be a little kinder than necessary, says Peter Lachman. Thank you for joining me on this journey. Take care, reflect deeply, and continue to forge the trust that binds us all in the act of care, also when things go wrong. And do not forget, we do not only have to take care of our patients, their kin, and of each other. The most important thing to remember is that self-care is really not selfish.